Hi, it's Dr. Winbush with Sankofa Healing Arts and Functional Medicine, here today to present on menopause and perimenopause and to answer some of the common questions that people often have. So, I am a board certified family physician with additional training and certification in integrative and functional medicine. And I, in addition to that, provide medical acupuncture and some energetic therapies at my private practice in Durham, North Carolina. I'm also able to work with folks virtually if you're not in North Carolina, but based in California, Minnesota, or Georgia. So, just the usual disclaimers that anything I say here is really intended for informational purposes, and that if you have some specific questions about how this information relates to your health and any health conditions you have, that you should consult with your healthcare practitioner. So, before we get started, I always just like to acknowledge that our health happens in a context, and it's a context that unfortunately and increasingly we recognize is impacted by things like racism and sexism, heterosexism, classism, and that all of these various identities can, and how people are treated who possess these various identities, can impact access to care and health status. And this is something that myself and obviously many people are working to eradicate, but it is the current reality. So, the first question that I want to answer and make sure that we're all on a common platform of understanding is, what is menopause and perimenopause? So, menopause refers to the end of the cycle, and specifically, it's a retrospective, meaning looking back in time definition, meaning that, or defined as when you are 1 year after your last cycle. So there are these subtypes of menopause based on the age at which somebody enters menopause. And so natural or spontaneous menopause generally occurs between the ages of about 45 and 52, sometimes a little bit later, and probably on average, most people around the age of 50 to 52. There can be the same transition happening, meaning it's been 1 year elapsed since the last period. But if you enter that transition between the ages of 40 and 45, that's considered early menopause. And similarly, if you enter before the age of 40, that's considered premature menopause. And you'll see written in red there, HRT indicated, because there is really solid evidence that if you do go through this menopausal transition on the earlier side, that there can be associated increased risk of cardiovascular disease, cognitive issues and decline, and that there is pretty clear evidence that HRT can help with that. Meaning, by HRT, I should say hormone replacement therapy, and that you should take that up until the age at which you would have. Um, an, Up until the age at which sort of the average person would go through menopause. So, usually through the age of at least 52. Another type of menopause is medical or surgical or induced menopause. And this is often an abrupt transition that can be due to surgery, radiation, various cancer therapies, or medications. And so, depending on why someone is entering that surgical or medical menopause, there may be an indication for hormone replacement therapy. Obviously, if it was for something like a breast cancer, hormone replacement therapy would not be indicated. The other thing that I forgot to mention is that premature menopause is often due to some underlying autoimmune condition, often due to conditions that can impact the ovaries and their ability to release certain hormones. So, perimenopause is the time from the onset of the initial symptoms associated with, you know, the approaching menopause and the actual menopausal transition. And so during this period, if you look at this diagram here, you'll see that during what they call the reproductive years, you have this normally cycling estrogen and progesterone kind of with each cycle. And then here in the perimenopausal period, you start to see that the release of those hormones and the levels of those hormones become more erratic. There's less of a clear cycle. And then in menopause is when the hormone levels, especially estrogen, decline. So a lot of the symptoms that people are experiencing during perimenopause are actually due to the hormone fluctuation, especially as it relates to estrogen, rather than the decline. Progesterone does seem to fall off a bit earlier. And for many people, perimenopause will start in the mid 40s. There is pretty clear evidence that for African Americans, on average, perimenopause will sometimes start sooner, more like the early 40s. And the symptoms of perimenopause can last several years, on average 4 to 8 years, but sometimes 10 years or more. And this is just some of the same information that I just went through, just laid out graphically. So, average menopause 45 to the 50s, early 50s or beyond, early menopause between 40 and 45, and premature menopause before 40. So, the next question I'd like to tackle are, what are some common experiences during menopause? And my use of the word experiences is intentional. I think it's good to remember that menopause is not a disease state. We hear so much, and it is true that there are various experiences and symptoms that are less than pleasant and that, may need some additional support and treatment. But I think it's foundational to remember that this is not a disease. And so, some of the common experiences that people face during menopause are the irregular cycles that we saw on that diagram just a couple slides ago. Also, vaginal and bladder symptoms, uh, uh, vaginal dryness, decrease in lubrication, changes in the skin of the vaginal walls, decreased ability to become pregnant, obviously, as this menopausal transition will signal the end of the fertile period. There can be mood changes, including anxiety and depression, and sometimes that can actually be the presenting symptom of the perimenopausal transition. Similarly, changes in weight and also body composition, how you're carrying the weight, increased fat, decreased muscle, which along with that can occur a loss of bone density. There can be cognitive changes, sleep changes, hot flashes, and night sweats. And again, some of this is due to the variability of the hormone levels, and some of this is due to falling levels of hormones. And again, not to overwhelm one or to program that these will be all of the things that you experience, but this is a even more extensive list of some of the experiences and symptoms that people can um, deal with in the menopausal transition. And I think it's helpful just to have some familiarity with these, because it allows you to better advocate for yourself or advocate for loved ones who might be experiencing, a variety of symptoms. And sometimes, especially due to fragmented care and people getting care in various places, there may not be dots connecting saying, oh, this could be menopause. And I think even when you have all of these different symptoms, if there's the understanding that there is potentially kind of one common source, it can have a um, helpful impact just psychologically, instead of feeling like so many different things are happening and there's no explanation. It can also sometimes point to a more efficient way to address those symptoms. And again, to counteract that narrative of menopause as disease, I think it's also helpful to think about the opportunities of menopause. And so I won't say a lot about this here. I do provide a reference there. The work of Dr. Christiane Northrup and one of her books, The Wisdom of Menopause. But I think there are other people talking in this space, and there's a lot that's happening on kind of the psycho-spiritual level that relates to this phase of life. And it often is a chance to sort of revisit emotional material that may have gotten submerged or buried. It's an opportunity often to reconnect with passions and with creativity. And part of that is because at this transition, which in some ways is like a second puberty or adolescence, our body is changing a lot and providing often really exquisite real time feedback about what our body needs to be able to maintain its balance. So, a common question is often, can I just get tested to see if I'm in menopause or perimenopause? And there's a few ways to answer this. I mean, the short answer is that there isn't a test for menopause. What is often recognized and what is often done is that when you have been 1 year without a cycle, uh, if you test a specific hormone called the FSH, which is actually a hormone that's made by the brain to stimulate the ovaries, you will see that that level is elevated, usually greater than 30. Some people would say, well, if it's elevated a year, what if I've missed 3 cycles? It's been 3 months. Can't we just test the FSH then, and I'll know that I'm in menopause? And while it doesn't happen all of the time, it can happen that because those hormone levels are fluctuating, the estrogen level, the progesterone level, as well as these other hormones like the FSH, it is possible to have that level tested, have it be in the menopausal range, and then a few months later to have it drop back into the non-menopausal range, to have the return of cycles. And so, especially if fertility or contraception is in the mix, it really is sort of best to wait for that formal definition. Uh, there are a couple of caveats. If you are starting to experience perimenopausal symptoms or going through this transition much before what would be the average age, so if you're in your late 30s or early 40s, especially if there are unrealized desires around family planning or having a child, then at that point, more specific testing may need to be done and more support for assisted fertility or assessing what your options are. Similarly, in the integrative and functional medicine space where I work, there is a whole range of additional tests that can provide more specific information around what's happening throughout the cycle, about how our body is managing certain hormone levels. And that can be useful. For instance, if people are experiencing a lot of perimenopausal symptoms and we're trying to target some treatments towards that, or also if people are considering starting menopausal hormone replacement therapy or menopausal hormone therapy and wanting to further get some information about their potential risk factors. So, another question is, why is this so complicated? I have hot flashes. Don't I just need to take some estrogen? And there's a couple things to say about this. The first is that not all hot flashes are caused by estrogen. While there are a specific type of hot flash, the menopausal hot flash, which often sort of starts kind of in the center of our chest and can radiate up to the head. And that is due to the fluctuations and often the diminishing levels of estrogen, and how it interacts with these neurons or these nerve cells in our brain that help us to regulate temperature. That is not the only reason that people can get hot flashes. And it's also not just about being a low estrogen state. Otherwise, people who have long passed menopause, or maybe 20 years without a period would still be hot flashing, which in general people don't. Or prepubescent girls who don't have significant amounts of estrogen floating around, again, would be having hot flashes. So it's not all about estrogen. And what you see here is a pyramid, and you see that there are levels to this pyramid, and at the base of the pyramid are things like blood sugar balance and stress resiliency. And so this pyramid is about all of the other sort of foundational hormonal and health aspects upon which sit at the top the sex hormones, things like estrogen and progesterone. But all of these things at the base really help establish a foundation so that whatever sex hormones we're making ourselves, or whatever we might choose to take if we choose menopausal hormone therapy, are going to work their best. And so blood sugar regulation is really important, and actually fluctuating or falling blood sugar levels can be a sign of hot flash, or can be a reason for hot flashes. Similarly, issues in the intestines and in the gut, and inflammation that is there can impact how we're managing or handling our estrogen. Similarly, our nutritional status, whether or not we are getting in all of the nutrients that we need to be able to biotransform and eliminate the hormones when they're no longer needed. all of these things, including thyroid function, high functioning thyroid, like elevated thyroid function or diminished thyroid function, can all potentially contribute to or be a cause of hot flashes. So these are things that you want to assess and address before necessarily just starting menopausal hormone therapy. So, kind of referring to that pyramid and this idea of setting a strong foundation, how can we smooth the menopausal transition? Well, one really important part is what I'm trying to do with this presentation, and I think what many people who are facing this menopausal transition are recognizing now is that we need to be sharing information, we need to be sharing experiences, and doing this in a community way that removes the stigma and allows for intergenerational knowledge. And so a lot of us may not be able to get that necessarily in our family of origin, but creating these intergenerational relationships in these places where people who are at various stages of this transition can come together and learn. And beyond that, one of the foundations is our practices around nourishment. And so we're going to talk about sort of three key foundational areas: nourishment, movement, sleep and rest. And any one of these could actually probably be a presentation in itself. And so I'm really going to hit the high level points and give you a place to start. So one key area is is plants, in that we need to be eating lots of vegetables and fruits. We want to have a plant forward diet. I'm not here to say that you need to follow a vegan diet or a vegetarian diet, but one of the things that's common between most of these, quote, healthy eating approaches, whether it be um, a Mediterranean diet, a paleo diet, is that most of them are very plant forward, plant foundational. And when we say lots of plants, in general, we mean probably about 6+ servings a day, which for many people is like two big handfuls. And you want that diet to be diverse and richly colored in terms of the plants that you're eating. There is some special benefit for like the broccoli family in terms of how they help us to manage and regulate hormones. We also need to be ensuring at this phase of life that we're getting adequate, high quality protein. And I don't generally like to make eating a math equation, but it is helpful here to kind of say what that means. And for most of us of kind of an average size or lean body size, it means about 30 grams of protein at each meal. And so a lot of people might say, well, I don't know what that is. You can start to look at labels or look these things up, but to just give you some idea, 30 grams of protein, it's like a cup and a half of Greek yogurt. It's a cup of tempeh. It's a cup of cottage cheese. It's 4 ounces of chicken, which is about sort of the size of the palm of your hand. It's 2 cups of black beans. It's 5 eggs. So most of us are not going to eat 5 eggs at breakfast. So if you're having a 1 or 2 egg scramble, you're not getting your 30 grams of protein. It's also 5 ounces of salmon. And so that protein is going to be really important for helping us maintain and build muscle, which we generally are starting to lose in this perimenopausal transition. You also need good quality fats like nuts and seeds and avocado, olive oil, even some butter or ghee, um, and whole unprocessed grains and starches. Some of the things that you want to limit or edit out are obviously the sugar and the concentrated sweeteners. Those are going to cause lots of fluctuations in blood sugar, which is a stress to the body. And then also these processed seed oils and just processed foods in general. So the second part of that foundation is movement. And movement does everything. It's good for our brain, it's good for our bones, it's good for our muscles, it's good for our heart, all of which are key areas that we want to be maintaining the health of as we're moving through this transition. And so the really affirming thing I want people to know is that you want to start where you are. If you're really sedentary, you haven't been doing much, it is not too late. And the evidence really bears that out, that doing anything is better than doing nothing. And while we, you know, used to kind of put out these recommendations about you need to do 300 minutes or 150 minutes of physical activity a week. And certainly those are goals to shoot for. And we often, I've been in medicine long enough where we used to say, and each bout needs to be at least 15 to 30 minutes. And we've constantly now been sort of bringing that down. And there's been lots of studies that show even doing like 1 or 2 minutes of activity, maybe ideally a few times a day, that when they follow a group who does that versus a group who does nothing, they see clear benefit in the group that's even just doing a couple minutes of activity at a time. And ideally, you want to cross train because it's going to help you prevent injury. So, doing different types of activity. And some of the elements to include, key element to include and to probably prioritize above the others even, is resistance training. And resistance training can be with your body weight, with bands, with actual weights. But again, we want to counteract the muscle loss that's occurring during this phase of our life. And one way to do that is through resistance training. But you do also want to maintain flexibility through stretching, through yoga, through just getting down on the ground and rolling around and playing. And you want to have some aspects of cardiovascular fitness training, which is also really good for the mood and obviously good for our heart. And then the sort of third key foundation is sleep. Sleep is the time when we repair. As we get older, there is more wear and tear on the structures of our body. And so we need to be providing the nutrition and the nutrients and the building blocks to keep things in good working order. But we also need to provide the space and the time for that to happen, which is when we get our sleep at night. And they used to say that older people don't need as much sleep, and that's because they would see them maybe not sleeping as much. And that's usually because there can be issues and health conditions that affect sleep. But most elders, those can be treated. And the evidence really shows that most people to function optimally need 7 to 9 hours of sleep nightly. More than 9 is generally possibly problematic, but less than 6 to 7 is also problematic. And we also want to start thinking more, and there certainly has been a lot more happening in the popular culture, elevating this about the importance of rest. And rest is different than sleep, and rest comes in different flavors. And some of these flavors are actually very active and engaged. And so I will invite you to spend some time looking at this graphic here and some of the descriptions and just doing your own rest inventory and where you maybe are achieving these different forms of rest and where maybe you could benefit from adding some other approaches. So, what can you do to manage symptoms? So, I am an integrative physician. I mostly work in the arena of non pharmaceuticals. So, I want to start by talking about some of the supports that I really like. And I'm going to start with the things that are sort of most food adjacent and then move towards those that are closest to medication and then actually move to medications and talk a bit about hormone replacement therapy. So, I really love herbs that you can use in teas. And here are some of my favorites. I really like red clover, oat straw, nettles, and you can usually get these dried herbs. Perhaps there's a place locally, like a food co-op, where you can get some of them in bulk, or they can be ordered online. And if you want to go to my website, I actually have a blog post that wrote a few months ago about some of the different teas and infusions, and I'll try to remember to link that in the description below. But red clover is great for menopausal symptoms and generally specifically vasomotor symptoms. It's also, all of these are rich in minerals, which are going to help support the structure of the bones and just general vitality and also of the skin. And so you can do these as teas where you add a teaspoon or two to hot water. But I also like to do them as a much more concentrated infusion where you might take half a cup of these bulk herbs and put them in a mason jar, pour boiling water over it, and then let it steep for a few hours or even overnight, and then drink it the next day. In terms of other herbal supports, I really like Siberian rhubarb, which these are going to be coming usually in supplement forms. Siberian rhubarb you can get in capsules, and there have been some small studies that show that Siberian rhubarb is maybe equally effective to low dose estrogen for vasomotor symptoms like hot flashes and night sweats. Black cohosh, too, also available sometimes in tincture, but often in capsule form. Helpful for vasomotor symptoms, also for like the body aches and the mood symptoms, the doom and gloom type of depression feelings that people can get in menopause. And both of these are generally safe and well tolerated. I do have a caution. I should go back here to say that with red clover, there is some theoretical risk that it can have some blood thinning properties. So if you are on a blood thinning medication or have a clotting disorder, or also it's questionable whether they have some mild estrogenic effects. So if you've had a history of breast cancer, you probably don't want to use the red clover. So now also some foundational nutritional supports. Vitamin D deficiency is really common, super important for our bone health, blood sugar regulation, immune health. So often people can benefit from some supplementation, sometimes on the order of 2 to 4,000 units a day, but you should get your level checked. And I generally like to see the level at least a bit higher than the lower end of normal, so around 40. Magnesium is a key mineral. Many of our soils in which we grow our food now are often deficient, and so our needs also increase with aging, and it's very helpful to support sleep and energy. So there are various forms of magnesium, some of which can be a laxative effect. So you want to choose the right form, and sometimes can benefit from 2 to 400 milligrams daily. Omega-3 fats are these essential fats found in things like flaxseed, salmon, and higher levels are associated with a lower risk of heart disease. It's an essential fat that we need to include in our cell membranes. It's helpful for mood. So sometimes, unless you're doing several wild fish meals a week, some omega-3 supplementation can be beneficial. And then what we haven't talked about explicitly is that our gut, there are digestive symptoms that can occur in perimenopause, often due to estrogen, the loss of the estrogen effect on our gut and our microbiome. So trying to get in more probiotic foods or potentially even taking a probiotic supplement can be helpful. And I again will not go through this in sort of the interest of time and trying to keep this presentation under a half hour, but this is a couple of tables that you can reference. And this is just kind of giving you a little window into kind of how we might start to think about an integrative plan for some of these health conditions. And then in this box, we talk about just some further description or notes about what those health conditions are, and then some various treatment approaches. So for instance, for the vasomotor symptoms, which are hot flashes and night sweats, there are studies that suggest the benefits of meditation and yoga and acupuncture and breath work. And then we already talked about some of these herbal supports, as well as other things you can do, like avoiding spicy foods and red wine and caffeine. Similarly, for the genital urinary symptoms of menopause, those entail some of these symptoms here. You want to maintain blood flow to the area with stimulation. You want to stay hydrated. And there can be vaginal lubricants or even DHEA creams that can help. And then I will let you kind of look at some of these other recommendations for mood fluctuations, for the changes in body composition, many of which we've already talked about. And then on this slide, we talk about sort of the memory and cognitive concerns and some supports for that, the digestive symptoms, and then the bone and skin health. So in the final minutes, I want to talk about hormone replacement therapy, or what's actually now being called menopausal hormone therapy. And it's interesting to kind of have a little bit of the history of the timeline about what's been happening over the past 60 years. So hormones really kind of came into their own in terms of a popular recommendation in the 60s, where they were talked about as being the fountain of youth and helping people in a very cis hetero way to be feminine forever. And then in the 1970s, it was actually found that they were associated with high rates of endometrial cancer. And so they were, at that point then kind of considered poison, and fell out of favor. And then in the 80s, they became popular again when it was realized that combining them with progestins, which are like synthetic forms of progesterone, helped to prevent the endometrial cancer. And so that use continued to grow until 2000, when this large study, the Women's Health Initiative study, published some of its initial findings, suggesting that there were actually increased risks of cardiovascular disease and breast cancer. However, it was later realized that there were really significant limitations in this trial. I won't go into a lot of the details here, but that a lot of these risks that they were finding were actually in people, women who were older, over the age of 65. And so it appears, and this is what we'll talk about in a minute, that if you start hormones very close to the menopausal transition and often discontinue them before the age of 60, that they can actually be helpful or beneficial. And so that's kind of where we are now, this understanding that there was some misinterpretation of those Women Health Initiative reports, and that there are these potential benefits to hormone replacement therapy. And so, what are the general principles of prescribing? You want to dose at the lowest effective dose that's going to relieve your symptoms. And you do want to start within 10 years of menopause. It is still a bit unclear as to when is the best time to discontinue, but it does seem that there is some somewhat slightly increasing risk of things like breast cancer, possibly cognitive health concerns when you do choose to continue. But it also is recognized that, for instance, people who start hormone replacement therapy for osteoporosis prevention, that when you discontinue the hormones, you're then going to have this precipitous fall off in your bone density. The ideal forms are estrogen and progesterone if you have a uterus. And the hormone form that's ideal is estrogen as a skin applied or patch, and then progesterone as oral. If you're just experiencing vaginal symptoms, then there are vaginal only estrogen preparations that are fine, and those don't need to be taken with progesterone. So, as it stands, the FDA has approved hormone replacement therapy for 4 specific indications: the premature or early menopause, which we discussed at the beginning of this presentation, vasomotor symptoms, things like the hot flashes and the night sweats, vaginal symptoms, in which case you actually would just be using probably a vaginal preparation if that's the only thing they were experiencing, and for the prevention, but not the treatment, of osteoporosis. There are additional possible indications for HRT, some of which I'll list here, but these are not FDA approved. There is some evidence that menopausal hormone therapy can reduce the risk of diabetes by about 30%. So, it could be a discussion that someone would have with their provider if they're at significant risk for diabetes, about the potential benefit of going on hormone therapy. Cardiovascular disease prevention is not a sole indication, but there is evidence of lower cardiovascular disease risk when the hormones are started before the age of 60, and brain health benefits if started at the age of less than 60. But the study results are still a little bit unclear. What are the contraindications? Contraindications are breast cancer, an active or recent heart attack or stroke, liver disease, and clotting disorder. There also are cautions if you have elevated risk for breast cancer, problems detoxifying estrogens, or a history of conditions possibly associated with elevated estrogen levels. And then the risks depend on age, but as we specifically talk about things like breast cancer, it looks like there's about one additional cancer per 1,000 people using hormones for 5 years, especially when they are continuing beyond the age of 60. So, in summary, menopause is a natural life transition. It's defined as the cessation of the menstrual cycle for 12 months. The average age at which this occurs is the mid 40s to the early 50s. And if it's occurring much earlier, honestly, than even 50, you should consider additional evaluation and management with HRT for that early menopause. Perimenopause is the period of time kind of leading up to menopause where the hormone levels begin to fluctuate. And the experience of menopause and perimenopause is going to vary. There are lifestyle choices and practices that can support a smoother transition, and there are a variety of non medication and medication based approaches that can also be helpful, including HRT. HRT appears to be likely safe for menopausal people who do not have contraindications to hormone replacement therapy and in whom therapy is started within the first 10 years of menopause. The evidence does suggest that it may also reduce the risk of diabetes, and it may protect against heart disease if started within 10 years of menopause. But after 10 years, that risk may elevate. So, like all things, decisions around menopausal hormone therapy and other therapies need to be individualized. So it's my pleasure to be able to provide this presentation to you. If you're interested in more information, you can get a copy of this slide presentation, and additional resources are available at sankofahealingarts.com/menopause talk. And feel free to ask questions or comment below. Thank you so much.